The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is New Horizons in External Beam Radiation for Brain Tumors. Thank you to today's webinar sponsors, Orfit and Accuray, for their support of this program. My name is Ambreen Mon, Program Manager at the ABTA, and I'm delighted to introduce today's speaker. Dr. Joseph Bovi is a professor of radiation oncology and an adjunct faculty at the Medical College of Wisconsin in Milwaukee, Wisconsin. He has also recently taken on a new role within private practice at Theta Care Regional Cancer Center and has over 20 years' experience in treating central nervous system malignancy. His research interests include the utilization of advanced MRI imaging and imaging biomarkers to personalize radiotherapy for patients with malignant primary brain tumors or metastatic disease to the brain. Thank you so much for joining us, Dr. Bovi. You may now begin your presentation.
Thank you so much. I just want to make sure that you can hear me okay and that my slides are being seen right now.
Yep, you sound great. Thank you.
All right, sounds good. Thank you so much. And Ambreen, thank you for the invitation to come and chat today. It's always a pleasure to speak to the ABTA audiences. I've always found these to be engaging discussions. And I also like to thank our sponsors, Orfit and Accuray. Today, we're going to take a deep dive into radiation therapy and specifically radiation therapy for brain tumors and drill down into some of the granular details of radiation dose rate. Conventional radiation therapy has been around for decades, but current clinical research, in addition to advancements in the radiation treatment delivery machines that we use, now allow for modulation or changing of the rate of radiation. And we understand and now know that this modulation can have an impact on tumors in a positive way. We're able to control tumors in a better way and minimize deleterious radiation side effects. We'll save all questions to the end. We'll talk for about 40 minutes and hopefully have a chance for 15 or 20 minutes of questions there afterwards. So at the end of this discussion, I hope that you will have a better understanding of the external beam radiation and its conventional role in treating brain tumors. And then we're going to explore some differences in dose rate principles, including standard and some experimental options for radiation therapy that are emerging. And then we're going to discover how new developments may improve survival, minimize side effects, and enhance quality of life for patients with brain tumors, both during and after treatment. So I thought we'd start with an overview of external beam radiation therapy. When someone says that they're receiving radiation, what they're meaning is that they're receiving ionizing radiation to treat their brain tumor. And you can kind of think of radiation therapy as extending the blade of our surgeon. There's not many cancers that we treat with curative intent in this day and age, including brain cancers, where we're not including combinations of surgery, radiation, and chemotherapy in order to render a patient cured. The surgeon, especially in brain tissue, can remove what appears to be grossly abnormal tumor, but we know that there are fingerlings of tumor, especially in malignant brain tumors, that can extend beyond where the surgeon is able to safely treat. And that's where the benefits of ionizing radiation come in to kind of go where the surgeon's blade can't. Here we see an example of a patient who's receiving radiation for a brain tumor, and we see a common immobilization apparatus that we refer to as an aquaplast mask. And the radiation is going to come out of the head of the machine that can be seen behind the patient there. And then here we see a representative example of a radiation dose plan on the right, which was what I would evaluate then to determine whether this radiation treatment plan is safe, with the higher doses of radiation being indicated by this red volume, and then the lower doses of radiation being indicated by the blue and the green volumes that are extending away from that. We use radiation to treat all kinds of tumors in the central nervous system. The most common indications for radiation for brain tumors include malignant gliomas, what people refer to as brain cancers, in addition to cancers that spread to the brain from other areas of the body, what we refer to as brain metastases. But almost as common as what we use for malignant disease, we know that radiation can be used to treat non-cancerous disease in the brain as well, like meningiomas or vestibular schwannomas, or even abnormal collection of blood vessels in people's brains that we call AV malformations. So across the spectrum of both benign and malignant disease, radiation for brain tumors and tumors of the central nervous system is a key player in controlling this disease process. So at the end of this talk, I don't expect you guys all to be radiation physicists, but I do want to try to educate you with regard to some radiation biology, because I think that will help a little bit with the explanation for understanding what's conventional treatment and then unconventional treatment. So we know that radiation dose rate is incredibly important with regard to our ability to control tumor. And I think in order to understand how we control that tumor, it's important to understand how radiation impacts tumor cells such that when that cell tries to divide, it dies. We're going to draw our attention to the lower left down here, and there are two ways that radiation can impact a tumor cell's DNA such that when that cell tries to divide, it dies. One way is what we call a direct approach, where that high energy particle, whether that's an electron or a photon, can actually directly damage that DNA, such that when that cell tries to divide, it undergoes a cell death process that we refer to as apoptosis. The other way that the radiation can impact a tumor cell's DNA is through an indirect approach. And that's where the radiation can actually cause the creation of what we call a free radical. And that free radical then is what causes damage to that cell's DNA, such that when it tries to divide, it dies. Okay. So the whole concept here is that we're maximizing injury to tumor to kill it, but yet minimizing injury to surrounding normal tissues such that side effects are not extreme. Um, there are important differences with regard to conventional radiation compared to unconventional radiation that we'll take a deeper dive into in a little bit. When I talk about conventional radiation, this is what you're going to be receiving 95% of the time when you're going and getting a course of radiation for a brain tumor. And what conventional radiation means is that it is on the order of fractions of a gray that is delivered per second. And for those of you who don't know what a gray is a measure of radiation for what myself as a radiation oncologist prescribes to a tumor. And a gray stands for the amount of energy that's being absorbed by tissues. And it's that energy that's absorbed that lends itself to this DNA damage. So conventional radiation therapy is on the order of a fraction per gray per second. But on the opposite end of that spectrum, and what we'll talk about as far as some emerging experimental radiation techniques, we refer to as flash radiation therapy. Now, flash radiation therapy, unlike conventional radiation, delivers an incredibly high dose of radiation in an incredibly short period of time. So conventional radiation takes a couple of minutes to deliver its dose of radiation, whereas flash for the same amount of radiation can deliver that dose within a millisecond. And the dose is actually significantly higher than what we see for conventional treatment. And there are some unique applications and perhaps benefits of utilizing this type of radiation, flash radiation, to treat tumors more effectively and minimize side effects from that radiation over conventional treatment. So what we're going to do first is to kind of look at an overview of the radiation dose rate spectrum. We're going to start with talking about conventional radiation dose rates and then move on to flash radiation, which I have to highlight is experimental and not for use in humans yet, but offers amazing promise for treating tumors more effectively. And then the other end of the dose rate spectrum, what we call pulse low dose radiation therapy. And so that is what creates that spectrum of radiation dose rate. Flash at one end, which is incredibly fast, conventional radiation in the middle, and then very low dose rate radiation, which is where we get PLDR. So let's talk a little bit about conventional radiation dose rates. Conventional radiation, as mentioned, is utilized in the majority of radiation oncology centers in the United States. And the benefit of that conventional radiation has been proven in countless clinical trials in central nervous system disease is to control tumor and improve patients' quality of life. The amount of sophistication that is currently involved in a radiation treatment plan is really impressive. You know, back in the day at the birth of the field of radiation oncology, they could only shape a radiation treatment beam into rectangles and squares. And in this day and age, we have almost an unprecedented ability to shape that radiation dose cloud so conformally to our target and minimize adverse doses of radiation getting to normal tissues, which has had a significant impact on improving patients' quality of life with brain tumors. And we're going to talk about in a little bit more detail some of these advanced radiation delivery techniques, one of them called intensity modulated radiation therapy, or IMRT, another called VMAT, or volumetric arc therapy. And then both of these two, IMRT and VMAT, can utilize image-guided radiation therapy to actually make sure that the radiation on a daily basis is being delivered with much more accuracy. So let's start our discussion of some of these advanced conventional radiation modulation techniques, the first being intensity modulated radiation. So intensity modulated radiation uses multiple beams of radiation of different intensities shaped to a patient's tumor. Sometimes those beams can move in an arc, or they can be treated in a stepwise approach in a circumferential manner around the patient. And the radiation intensity of each beam can be controlled in order to control where that radiation is going to. And so down below here on the left-hand side, we see what would have been an old school radiation approach that we would have called opposed lateral radiation beams that's delivering a dose of radiation to this centralized tumor that is outlined in yellow. So sure, the prescribed dose of radiation, which is in red, is covering that tumor in its entirety. However, the problem is that we have almost as much of the prescribed dose of radiation not going to the target as we do actually hitting the target. So let's fast forward to present day, where we have multiple different beams of radiation that are treating this patient's tumor in a much more conformal way. And here we see that the prescribed dose of radiation in red to this yellow target is much more conformal and sparing normal tissues to a much higher degree than what these old school radiation techniques could do. Now, there are some drawbacks to IMRT. Of course, the benefit of it, as we said, is that we can shape radiation much more precisely to our intended target. But the downfall, as we had seen in that previous slide, is that there's much more scattered low dose radiation to other surrounding structures. The good news is that low dose radiation is not thought to be deleterious to those surrounding normal structures, and so patients' side effect profiles won't be increased. The good news, too, is that your radiation oncologist is going to know exactly if this is the appropriate treatment technique for you, and to be able to design a radiation treatment plan appropriately to treat the target and minimize low dose to surrounding normal structures to make sure that your symptom profile is kept under good control. The next type of radiation modulation that we'll talk about for conventional treatments is VMAT, or what we call volumetric arc therapy. And this is a very sophisticated radiation treatment technique where a cone beam actually rotates around the patient in an arc in a circumferential manner around the patient. And the shape of that beam as it's moving can be adjusted en route. The great thing about that is that the radiation dose, the beam shape, and even the speed of rotation can be changed as the beam rotates, and can deliver an incredibly precise dose of radiation to the tumor while minimizing exposure of normal healthy tissues, which again minimizes side effect for the patient. VMAT pros is that it can be much faster and more efficient than intensity modulated radiation, and you can treat the whole tumor volume at once. And it's particularly useful for treating tumors that are near sensitive body organs. I can deliver an incredibly high dose of radiation to a tumor that's living right next door to a sensitive critical structure and still not harm that sensitive critical structure. That's how great VMAT plans can be. But again, the con of VMAT, similar to intensity modulated radiation, is that surrounding low dose to normal tissues can be increased, but again, not to the degree where it would be deleterious for the patient or cause increased side effect profile. Now, both IMRT and VMAT can be utilized in conjunction with what we call image guided radiation therapy, or IGRT. And the concept of IGRT is that we're actually imaging the patient's anatomy and tumor prior to the start of the radiation therapy to make sure that our target is aligned with where that radiation dose cloud is going to go. There are even some radiation treatment delivery devices that can actually image a patient during the treatment delivery, looking for subtle motion of the patient's targets and critical structures so that we always know that we're spot on our target and not delivering an adverse dose of radiation to that surrounding critical structure. An important tool that I use is a device called CyberKnife, which delivers a very conformal dose of radiation to a target in a patient's brain or spine. So the important thing is that I want to make sure that that target is always within that radiation dose cloud. And the CyberKnife unit has a way with X-rays of making sure that that target is always within that dose cloud so that I'm reassured that my dose of radiation is getting to where it needs to go and it's staying away from critical structure like patient's normal brain and spinal cord. The cool thing about these devices as well is that with that imaging and understanding where that patient is at in space in relation to the tumor, actually adjustments to the radiation treatment beam can be made on the fly so that the radiation dose is always optimized to the tumor and minimized to surrounding normal structures. And there are multiple different types of treatment machines that can utilize this onboard imaging, utilizing both X-rays and MRI imaging to make sure that our target is being treated in the way that we intended. It's amazing technology, and I wouldn't be able to do what I need to do for my own patients absent this image-guided technology that we use with IMRT and VMAT. So these advances in radiation modulation and delivery have come quite a long ways. IMRT, VMAT, and IGRT, as we've mentioned, can increase precision of radiation dose to tumor while reducing toxicity. And one of the success stories, especially in brain tumors, that we can highlight with regard to the utilization of these advanced technologies is with a common application that we use sometimes in patients with metastatic disease to the brain, which is called whole brain radiation therapy. Now, for those of us that have been in this field for a long time, we clearly recognize the deleterious effects of treating a patient's whole brain with radiation. And some of my very smart colleagues, probably 10, 15 years ago, came up with a concept of saying, well, why don't we treat the majority of the patient's brain with whole brain radiation, yet avoid giving higher doses of radiation to central structures in the brain that are important for cognition and memory? And so this is where we had the birth of what we call hippocampal avoidant whole brain radiation therapy. We would not be able to achieve these radiation dose plans that we see to the right, where we're getting a very homogeneous dose or a fairly homogeneous dose of radiation to the surrounding normal brain, yet sparing these central structures of hippocampus and amygdala from getting high doses, which we know based upon clinical trials that were performed 10 years ago actually improves patients' quality of life by improving their cognition if they need whole brain radiation. So again, IMRT, VMAT, and IGRT made this more sophisticated treatment technique possible. So without these advances in these treatment machines, we wouldn't be able to deliver this far superior treatment to our patients who are in need of whole brain treatment. So we're going to look at this graph in a little bit more detail when we talk about flash radiation. But I wanted to bring it up here first to at least discuss for conventional radiation therapy what we hope to achieve with balancing the dose of radiation that we know the tumor needs to receive yet minimizing side effects to normal tissues. So as we talked about with conventional radiation, we're delivering a fraction of a gray per second. Okay, that is a standard conventional dose rate, and it's important that you keep this in mind, a fraction of a gray per second. But it's important to understand what that conventional dose rate does to both tumor and normal tissue. So as a radiation oncologist, this is always a balancing act in my mind, knowing that I need to deliver a certain dose of radiation to improve what we call the tumor control probability, or TCP, yet balancing injury to normal tissues, which we refer to as the normal tissue complication probability. The dotted lines here are normal tissue complication probability. The solid lines is tumor control probability. So as a radiation oncologist, I know that if I give a crazy high dose of radiation to a tumor, then my ability to control that is upwards of 100%. But along with that, though, that comes with a near 100% risk of me causing injury to surrounding normal tissue. So where's the sweet spot? We want to deliver a dose of radiation that still offers a high level of control, yet minimizes that complication probability. We'll come back to this in just a little bit. So what we're going to dive into next is where, in my mind, we put the pedal to the metal and we significantly increase that dose rate. And we're going to talk a little bit about this concept of what's called flash radiation therapy. Okay. And it's important to note as a disclaimer, we don't yet have human or inhuman data for the utilization of flash radiation. We don't have clinical trials that are yet being used with flash radiation. This is purely, but it will hold incredible promise, or does hold incredible promise, with regard to treating patients' tumors that would significantly minimize side effects to surrounding normal tissues. And we'll talk about how that works in just a little bit. So as mentioned, flash radiation delivers incredibly high rates of radiation. So remember the number that I asked you to remember before. Conventional radiation is a fraction of a gray per second. Flash radiation can deliver upwards of 100 gray within a second, even milliseconds. It's an incredibly high rate of radiation delivery. And the mechanism of action that makes it savory is that it optimizes injury to cancer cells, particularly those in what we call a low oxygen environment or a hypoxic environment, and yet minimizes radiation injury to normal tissues. And that's exactly what we want to try to achieve, right? Optimizing tumor cell killing while minimizing side effects to surrounding tissues. The problem with flash at this point in time is that there are limitations in the radiation treatment machines that actually can deliver this type of radiation. There are very few in the United States that can actually generate a beam that can deliver that high of a dose rate. These machines, oftentimes they're proton machines, are ridiculously expensive. And again, this is still in the experimental phase and not yet ready for in-human use, but it holds great promise. So as we mentioned, flash radiation delivers an ultra-high dose rate of radiation greater than 100 gray per second. It's delivered in a very, very short period of time. However, as mentioned, there are limitations with regard to that treatment beam, okay? So here we see a proton machine that can actually generate flash radiation out of this collimator head, okay? The problem with this is that it's fixed. It can't rotate. It delivers a beam only in a horizontal direction, only one direction, okay? We see much more flexibility with our conventional radiation treatment machines, where not only can the machine move around the patient, but the patient can swivel on the treatment couch in order to optimize radiation direction to the patient's targeted tumor and yet minimize that dose of radiation to the surrounding normal tissues. And so we see huge differences here in terms of the delivery, I think, with much more limitation in terms of beam direction with flash radiation at this time, compared to what we have come to enjoy as the flexibility of treatment with conventional radiation treatment machines. So as we've mentioned already, let me wet my whistle here. Flash radiation spares normal tissues from those radiation side effects. And the way that this is thought to happen, or the hypothesis surrounding how this is thought to happen, is that with flash radiation, it depletes that surrounding environment of oxygen, depletes the surrounding area in tissues of oxygen almost immediately. What happens with that then is that with that reduction, that immediate reduction in oxygen in those normal tissues, it prevents those free radicals that we learned about in the very beginning of the talk from forming, causing injury to normal tissue DNA, which can perhaps prevent radiation-induced inflammation from occurring. On the flip side, then, to tumor, we know that it maximally injures tumor tissues. And the way that it's thought to do that is that that high dose of radiation is thought to damage the lining of the blood vessels, what we call the endothelium. And with that injury to the lining of blood vessels, we know that that can disrupt the tumor's vascular network, which decreases the blood supply to that tumor, lending itself to enhanced tumor control. These are still concepts that are being studied as flash is becoming utilized more frequently in experimental ways. We're trying to understand a little bit better the biology behind where this normal tissue sparing occurs and how we maximize injury to tumors with the utilization of flash radiation. So as promised, we're going to come back to this chart again, okay? And so we know that with flash radiation, we can deliver the same dose, or an incredibly high dose of radiation actually, with flash radiation compared to conventional treatment. But the difference falls in the normal tissue complication probability. So while this incredibly high dose of radiation that's delivered with flash can control tumor to near 100%, what we see as a benefit with flash radiation is that the risk of normal tissue injury is much less than what we would see with conventional treatment. So for this same dose of radiation, we would see perhaps a 5 to 10% risk of normal tissue complication injury with flash, as opposed to a 45 to 50% risk of normal tissue complication with the same dose delivered with conventional radiation. And it's this widening of this therapeutic window that we think holds great promise, with flash radiation becoming a key player in our treatment of tumors, especially those that are in and around important critical structures that can't be and shouldn't be injured with radiation. So there are challenges with flash. So why doesn't everybody have flash? Why aren't we using this throughout the United States? Well, as mentioned, there's technologic constraints. Beam generation is very difficult, and there are few machines in the United States that can actually deliver it. In addition to that, then, with there only being a handful of sites that can actually generate a beam of this intensity, we're far away from having clinical trials being developed that are going to be used in humans to see if flash radiation is better than conventional radiation in the treatment of tumors. There are also regulatory challenges with FDA approval of machines that can actually generate a beam of this intensity. And as mentioned, we're just not using this clinically yet. There are machines that can generate flash. We don't have in-human trials yet, but they are coming down the line. So that's kind of a look into the future for what we hope to see with flash radiation. On the other end of the dose rate spectrum, we're now going to talk a little bit about pulse low dose radiation, which is a treatment technique that I had the opportunity to research heavily in when I was at the Medical College of Wisconsin. So pulse low dose radiation, in deference to conventional radiation and flash radiation, delivers subgrade doses over extended periods of time. So it's actually, instead of a fraction of a gray per second with conventional radiation, pulse low dose radiation delivers a fraction of a gray per minute. So it's a much, much lower dose rate than what we saw even with conventional radiation. The mechanism of action of how this type of radiation works is that it spares normal tissues, especially those tissues that have already previously been irradiated. And we also think that pulse low dose radiation can enhance the immune effects by allowing the human body's own immune system to attack that tumor when a tumor has been treated with pulse low dose radiation. And so here we see an example of a patient of mine that I treated in Milwaukee. This was a patient that had previously received conventional radiation therapy for a high-grade brain tumor, yet had recognized recurrence of disease about a year after the completion of their radiation. We gave this patient pulse low dose radiation to near the same prescribed dose of what their first course of radiation was. And here we see the patient's tumor at baseline. Here we see the patient's tumor at 3 months, which is much smaller than what it was previously. And then here we see the patient's tumor at 6 months. And so we saw a significant decline in that patient's tumor on these MRI scans that were performed with the addition of pulse low dose radiation. And what we don't see in these surrounding tissues is injury to surrounding normal tissues that had already previously seen a very high dose of radiation. And that's where this sparing of normal tissue with pulse low dose radiation comes into play. So pulse low dose radiation is here and is in clinical use at multiple sites across the United States. In fact, there are actually clinical trials that are pending in some of the national clinical trial organizations to actually bring pulse low dose radiation to upfront treatment. So the most heavily published areas of use for pulse low dose radiation is actually in recurrent brain tumors, both benign and malignant. And the success rates of those trials with the effectiveness of pulse low dose radiation in brain tumors was so high that, as mentioned, there's actually consideration being to clinical trials being used to treat patients up front with pulse low dose radiation as opposed to conventional radiation. So we understand that there may be some tumors and tumor pathologies that may make them more radiosensitive to pulse low dose radiation as opposed to conventional radiation, but we don't know the answers to that yet. That's where clinical trials have to come into play in order to help answer those questions for us. We certainly know that with the addition of pulse low dose radiation and chemotherapy in patients with recurrent malignant brain tumors, that we saw very impressive rates of tumor control, very minimal rates of side effects related to that treatment, and patients tolerated that therapy very, very well. The challenge, though, with pulse low dose radiation is that when the dose rate is so low, again, fraction of a gray over minutes, in order to deliver a meaningful dose of radiation on a daily basis, the treatment time on the treatment table is significantly longer than what it was in days past. So with PLDR, we're talking about 30 to 40 minutes on the treatment table as opposed to 5 to 10 minutes for conventional radiation. Some patients would have a very difficult time lying on the table for that period of time. So we're going to take a pause real quick from the discussions of dose rate. And at least for the members of our audience that are joining us who are not in academics and don't have a great idea of what radiation therapy is all about for treatment of brain tumors, we thought we'd take a quick pause and talk about some common patient-related questions about what it's like to receive conventional radiation. So let's start out for what is the treatment process like? So I wish that with radiation that I could just put a patient on the treatment table and the radiation would know immediately where to go. But unfortunately, there's a lot of work that goes into these radiation treatment plans. So first and foremost, you have to meet and have a consultation with a radiation oncologist so that they can talk to you about what's in store for treatment, go over what the side effects, risks, benefits, and alternatives of radiation therapy are for the treatment of your particular tumor. If all are in agreement with proceeding with radiation, then we do a CAT scan for radiation treatment planning purposes. And sometimes these CAT scans, especially with brain tumors, are coupled with a radiation treatment planning MRI in order for us to see that tumor with a higher degree of precision. After the CAT scan and the MRI are performed, the physician prescribes dose to tumor and gives limits then to what we don't want surrounding critical structures receiving as far as radiation dose. The doctor then delineates what the radiation targets are, in addition to delineating what the normal tissues are that we don't want seeing high doses of radiation. And then we have a radiation treatment planner that creates that radiation treatment plan, what we call a dosimetrist. The dosimetrist creates an appropriate beam arrangement and doses targets in normal tissues. And then the plan is optimized, and the dosimetrist and the physician then review that plan together. If there are changes that are necessary, edits are performed and the plans are re-optimized. And then ultimately, the physician will approve that final plan. After that final plan is approved, they're not ready for treatment yet. That's where our physicists come into play, where they will actually perform QA on the plan to make sure that what the dosimetrist and the physician approves is actually going to be delivered in real life from that treatment machine. Oops, sorry, I'm going to go back one slide here. After the QA has been performed and that plan has been approved by the physicist, then the patient is ready to be treated. What's important to recognize is that from consultation to treatment, this is a process that can take up to 2 weeks to occur. So again, like I said, I'd love it if we were able to put a patient on the treatment table immediately after seeing them in consultation and get their radiation treatment started. But unfortunately, there's a lot of work that goes into making a radiation treatment plan safe for delivery in order to make sure that the outcomes that we expect from that radiation treatment are what we want. So another question that I hear with frequency is, and especially for a treatment technique that I use quite a bit, is stereotactic radiosurgery. So stereotactic radiosurgery is where we're giving very high doses of radiation to very defined targets in patients' brains or spines in order to help control the tumor better. There are multiple devices in the United States that can deliver stereotactic radiation. One of them is called Gamma Knife. Another is called CyberKnife. You can even have linear accelerator, what we create as an acronym of a LINAC. You can have a LINAC that can deliver stereotactic radiosurgery as well. Which one is better? None of them are better than another, and all of them have pros and cons associated with them. Just to show you as an example, here we have a picture of a Gamma Knife unit. I had a vast experience with this for 20 years down at Frederick Medical College of Wisconsin. This tool works great. Limitations are that it can only treat patients' tumors in their brain. My current position here in Appleton, Wisconsin, we have a CyberKnife unit. Again, brilliant machine, can treat patients' tumors in their brain, in addition to tumors throughout the body, actually. This is a linear accelerator that is attached to a robotic arm that can rotate in any position around a patient to treat disease. It does a really, really nice job with stereotactic radiation. And then here we see an example of a linear accelerator that's outfitted with onboard imaging in order to deliver stereotactic radiation with a high degree of precision. Your radiation oncologist will know which device obviously they have to use at their own institution, and will know if there's a device that would be better suited for you than another, and make an appropriate referral if that technology is not available at their site and you would benefit from being treated elsewhere. So it's important for you to engage with your radiation oncologist in that discussion to make sure that you're being treated in the way that you should. And your radiation oncologist will be knowledgeable about what best technology is going to be to treat your tumor, depending upon your clinical situation. So how long does each radiation session last? Long or short answer to that question is it varies. Gamma knife or CyberKnife or LINAC-based stereotactic radiation can take 15, 20 minutes, sometimes even longer than that, to deliver an appropriate dose of radiation to a tumor. Standard conventional radiation treatments are delivered very quickly. Door to door, from when you check in to when you leave, is about 15 minutes. You come in, you check in, you get your treatment, and you leave. And that's what the majority of radiation treatments are like. And then finally, let's talk a little bit about concerns with regard to side effect. The side effects that I hear most about from my patients are hair loss, and then the concern for claustrophobia. Your radiation oncologist can prescribe calming medications for you if it's indicated, in order for you to make it through that treatment planning process in each daily treatment. However, there are a number of other side effects that can happen with radiation specifically for brain tumors. So hair loss, redness or irritation of the scalp, headache, nausea, vomiting, all of which we have great medications to help control those side effects if they occur. The most important long-term side effect that the majority of my patients ask me about is, how is my brain going to think when I'm done with treatment? And the good news is, as we talked about earlier on in the presentation, we have come to learn a great deal about important structures in the brain that we don't want seeing high doses of radiation in order to spare patients' cognition or how their brains work after treatment. And we have an unprecedented ability in this day and age to spare patient's normal, eloquent brain from high doses of radiation in order to optimize outcomes for patients' cognition after the completion of treatment. All right, so we're going to finish up here with a discussion on dose rate, ongoing challenges, and ongoing research, and where all of this fits in with regard to treating patients' brain tumors appropriately with which type of radiation. So at this point, there is current research that's happening that is looking at pulse low dose radiation and which types of tumors are best treated with that modality. As we mentioned, there are no in-human trials for flash radiation yet, but these are trials that are going to be coming down the pike as more centers gain the ability to deliver that type of radiation. So questions that we as academic radiation oncologists ask are, what tumors are best for each modality? What targets are best for each modality? What dose and dose rate do we use? And then what fractionation schemes do we use? These are all big questions to be answered in future clinical trials that we don't yet have the answers to. And of course, then that there's the logistical availability of flash, which, as we mentioned, is just limited in the United States. I think we need to have a much better understanding of, as radiation oncologists, about the radiobiology surrounding how each of these modalities work. And how we're going to get there is with clinical trials and then future implementation within human trials, specifically for flash radiation. We're going to skip that slide and move on to this. So I'm going to talk a little bit about where I kind of see future state with radiation therapy in terms of utilizing this spectrum of radiation dose rate in terms of treating disease. I think every cancer center, and you'll see this throughout any social media that you go on for any type of tumor treatment, is the personalization of your cancer therapies. And this is where we're heading to in radiation oncology as well. There's a whole field that we call radiogenomics that is actually looking at trying to match a patient's tumor biology specifically with radiation treatment. And this is, when I say radiation treatment, I mean radiation treatment across this spectrum of dose rates that we just spent the last 40 minutes in going through. So are there specific molecular rearrangements or genomics of a patient's tumor, or even biomarkers that could be tested with blood sampling that would help us predict better what type of radiation and what type of radiation dose rate might be best in order to treat that tumor with the maximum amount of control. And that's where I see the future of our field heading, is that we're going to be adapting these patients' therapies to their own tumor profile based upon what we know about the biology of their tumor for how they're going to respond to different types of radiation. So the other thing that we recognize that we need to do in radiation more, especially in brain tumors, is understand the synergy or how that radiation works with other treatment modalities. So as we talked about, there is a hypothesis that pulse low dose radiation therapy actually enhances the immune response to that type of radiation against a patient's tumor. So what if we coupled that immune response with drug therapies that can actually help rev up the immune response with chemotherapies or systemic therapies, thereby adding a synergistic approach or treatment modality to the radiation. So we give radiation, which increases an immune response, along with a drug therapy that further increases that immune response. And we allow the patient's own immune system to attack that tumor better than what each one of those modalities would have done on their own. And again, are there biomarkers that we can test for in blood specimens to say, we need to treat this patient's tumor with a certain type of radiation or a certain type of radiation dose rate combined with immunotherapy in order to optimize that patient's outcome with that tumor. This is future state, but I definitely see this happening in the near future. So we talk about adaptive radiation therapy, which is here right now. You know, we can do imaging of a patient's tumor during treatment and make real-time adjustments. But what if we had a blood test or an imaging biomarker that during the course of a patient's radiation treatment, we could see that we're not getting the appropriate response that we want with that therapy? What if then we were able to adapt the radiation dose rate or adapt that radiation dose rate with another systemic agent in order to better treat that tumor with a higher degree of success? You know, when I think about how we deliver radiation in this day and age, we do that radiation treatment planning session. We get a patient through 6 weeks of radiation treatment, and then we don't look again with another MRI scan until a month afterwards. Well, there's a whole bunch that's happening in that tumor, and there's actually research that's been done with MRI-based linear accelerators where they're imaging patients with MRIs during the course of treatment and seeing that these changes are happening in the midst of treatment. Well, what if we were to have a better understanding of those changes in the midst of treatment to understand who was responding and who wasn't? Could we modulate a patient's radiation dose rate or modulate even the dose of radiation in order to get a better response if we see that things aren't heading in the direction that we want? Again, this is future state, but things that I think are really exciting in our field of radiation to better adapt our treatment specific to patients' tumors and not assume that they're all lumped into the same pathologic group and going to respond the same way. And again, the whole goal of that is to enhance the effectiveness of tumor treatment while reducing the side effect profile to patients. And then, of course, with some of these radiation dose rates that are not for use in humans yet, like FLASH, there are, of course, regulatory and safety considerations that we have to consider. As a radiation oncologist and even just working with a group of oncologists, we oftentimes turn to guidelines and consensus guidelines that are published in the National Cancer Care Network, in addition to published from our professional societies like American Society for Therapeutic Radiation Oncology, or ASTRO, or the American Society of Clinical Oncology, also called ASCO. And we utilize those guidelines to help make our recommendations for how patients are going to be treated. You're not going to find flash radiation in any of these guidelines yet because it's not ready yet, right? We haven't done the clinical trials or the academic work to understand how they would fit into guidelines for treating these malignancies, even specifically brain tumors. And also important with that, it's just critical for us to have an understanding of the safety surrounding these treatments, and clinical trials will get us to that endpoint as well. And then once these treatment modalities become more available, of course, we have to keep in mind the ethics surrounding the equity of access for all of our patients. And again, I'm just going to highlight, ask your radiation oncologist if this is the best type of radiation for you to be delivering. Be a partner in your care. We welcome that. And I would welcome the discussion of any of my patients to bring to me those questions so that we can explain, hey, conventional radiation is going to be better for you, or hey, we're going to modulate this radiation dose rate and treat you with pulse low dose radiation therapy because of these reasons. And those are important discussions for you to have as future patients, perhaps, who are going to be getting radiation treatment. So, as I've mentioned, ongoing research is going to be critical to understand how we're going to utilize these differences in dose rate that have newly become available to us. Obviously, we need to expand the clinical applications for these new types of radiation therapy. And then, as mentioned, we certainly have a lot to learn with regard to the radiobiology of these tumors and how we're best going to utilize these radiation dose rates in order to improve outcomes for our patients. And with that, I'll close. Thank you so much for the opportunity to chat with you about this topic. It's been, it was fun to put this talk together, and I'm glad Ambreen challenged me with considering doing this topic. I had a lot of fun with it. But I'll pause there, and we have about 10 minutes for questions.
Thank you so much, Dr. Bovi. Just as a reminder for our attendees, if you do have a question that you want to ask, please type and submit it using the Q&A button at the bottom of your screen, and we'll try to get through as many questions as time allows. So Dr. Bovi, one of the first questions we have here is asking about getting radiation a second time.
Yeah.
Are patients able to get radiation again if they had already received it in the past?
So we're going to talk specifically with regard to malignant brain tumors. And I have to be honest with you, Ambreen, early on in the course of my training, my answer to that would have been no. We used to think that a conventional course of radiation, that we had maximized the dose to surrounding normal brain structures and that we were not able to successfully deliver more radiation to a patient's brain. That is just not true anymore. As we talked about, pulse low dose radiation therapy has been extensively published in the retreatment of recurrent malignant brain tumors and has shown great effectiveness in doing so. So much so that they're considering clinical trials, national clinical trials, in order to confirm that work. So, in this day and age, a second course of radiation therapy is not out of the question. And you definitely need to engage with your radiation oncologist to ask if that would be an opportunity for you if you do have a recurrent brain tumor.
And a follow-up to that, if a patient was previously told that they had met the highest amount of radiation that they can receive, and this is for someone who's sharing that they had gone through treatment over 10 years ago,
Mhm.
would it be a good idea for them to reassess that, talk to their doctors now to see if that's an option for them?
Short answer to that question is absolutely yes. And to chat with a radiation specialist for them to evaluate what that treatment plan had delivered as far as dose in that first course of treatment to determine what can safely be delivered in retreatment. And it's not just pulse low dose radiation that there may be of benefit. We certainly know that in the proton therapy sector, that there's opportunities for retreatment with the utilization of protons as well. So there's lots of options for folks with recurrent brain tumors who had been previously told you've received your maximum dose of radiation. We know that we have opportunities to retreat and to retreat safely in the recurrent tumor setting.
Thank you so much. And talking about pulse low dose radiation, is that an option for patients of all ages? This individual is particularly asking for older adults, 70 and older.
Sure. At this point in time, the clinical trials that have been done at single institutions have included patients that have been 18 years of age or older. I do know at some institutions that they are considering retreatment of malignant pediatric brain tumors as well. I just haven't seen as much published data in that patient population.
Thank you so much. And another question we have here is asking, you talked about flash and you talked about pulse low dose radiation as well and how it can help potentially help reduce side effects. Could these options also help to reduce necrosis?
And short answer to that question is going to be yes. Necrosis is an unfortunate side effect that can happen with certain types of radiation and in treating certain brain tumors. Um, the advancements in the radiation treatments that we had talked about, especially IMRT, VMAT, and perhaps more importantly, stereotactic radiation, really limit those doses, those deleterious doses to surrounding normal brain tissue, which would limit the opportunity for necrosis to arise. Necrosis does happen, though. I talk to my own patients that there's with a conventional course of radiation, anywhere from a 3 to 5% risk. With stereotactic radiation, we talk about a 10 to 15% risk of radiation necrosis, depending upon what we're treating. The good news is that there's opportunities for minimally invasive techniques to manage that necrosis. And those are things that you'll need to continue to engage with your radiation oncologist. They'll know how to manage that unfortunate complication in the event that it were to arise.
Thank you. And a follow-up question about necrosis. Is radiation necrosis permanent? Is this something that you see resolves over time?
So there's two ways that we approach necrosis. If we do see necrosis on an MRI scan and patients are without symptom, oftentimes we watch that. That's something that over serial MRI scans may just resolve on its own. Unfortunately, there's about 20% of patients that will progress on to symptomatic necrosis, at which point in time we have a number of different options for treatment available to us. One of those is a minimally invasive brain procedure that we call laser interstitial thermal therapy, which has shown great promise in treating patients with necrosis. There's also drug therapies that can be given. Drugs like Avastin have been shown to significantly reduce the side effects related to radiation necrosis and actually offer an opportunity for healing. And then outside of those two medical interventions, there's actually a homeopathic remedy called Boswellia serratia, which is frankincense, that there are preclinical trials that have shown amazing responsiveness to taking that supplement and reducing your risk of symptomatic necrosis. And so those are kind of the three approaches that we take for patients that do show up with symptomatic necrosis, but it's important for you to engage with your radiation oncologist if that does occur in order for them to best advise how that's going to be managed for you. Don't start taking Boswellia serratia on your own. Make sure that that's recommended by your radiation oncologist if that's something that's going to be utilized to treat that symptomatic side effect.
Thank you. Thank you so much for that caution as well. We have another question asking about side effects. Are some patients more likely to experience cognitive issues after radiation than others?
So I think in days past, my answer to that would have been yes. We certainly knew that in days of less sophisticated radiation treatment delivery, that those eloquent regions of brain that were important for cognition were certainly put at risk of older radiation treatment techniques. But as mentioned, with the advancements in modulation and the utilization of IMRT and VMAT, and for us biologically having a better understanding of areas of the brain to spare in order to optimize patients' cognition. In addition to that, even prescribing medications, particularly during whole brain radiation treatment for drugs like memantine that we know can have a radiation sparing effect by preventing cognitive decline in that patient population. We see much, in my opinion, much lower rates of cognitive decline in patients with brain tumors than what we did in days past. I think the other thing that we as a specialty have started doing and engaging is engaging our neuropsychiatry team early on in the treatment of patients with brain tumors and having these patients go through a battery of neuropsychiatric testing in order to understand how their brain works at baseline so that we can actually test in the future to see how those patients' brains have been impacted by the treatments that we deliver, because there are different medication regimens that can help make patients' brains think better, even following the completion of radiation. And it's important for us to engage with our neuropsychiatric colleagues in order to make sure that those medications are being prescribed in an appropriate way. So I think in this day and age, we know much more than what we did in days past. I think the risk of cognitive decline is less in certain patient populations with the advancement of these sophisticated radiation delivery techniques that we've just talked about. And there are continuing studies that are coming down the pike in order to further help limit that side effect that I know is most important on patients' minds when we talk about treating their brain with radiation.
Thank you so much. Another question we have here is on proton beam therapy. Can you touch on where proton therapy fits into all of this and what patients may be a candidate for that?
Sure, that's a great question. Proton beam therapy is particle-based therapy. It falls into the same dose rate realm as conventional radiation, what we talked about. There are a limited number of centers throughout the United States that actually deliver proton beam therapy. We're lucky in the state of Wisconsin that we will be activating 2 proton beam centers in Milwaukee and Madison within the next year. Proton beam therapy, I would argue, holds the greatest promise for treating pediatric malignancies. And the benefits of protons over conventional radiation is that we're able to deliver a dose of radiation where that energy is delivered over a specified range within the human body. And then there's very little entrance or exit dose. And so you can imagine in a pediatric population where we have growing organs and bones that we don't want excess doses of radiation getting to those surrounding critical structures. And so in kids, that's become very important. But I would argue that especially on our topic of brain tumors and brain tumor recurrence, and especially spine malignancies, proton beam radiation therapy holds incredible promise in terms of treating those tumors with a high degree of precision, optimizing our radiation dose to our target, and minimizing dose to those surrounding critical structures, which can cause bad side effects. Your radiation oncologist will know if protons are appropriate for you. There are definitely certain clinical scenarios where I would recommend protons. I don't have that technology available to me here in Appleton, and so I would refer a patient to a center that does. But you have to engage with your radiation oncologist in order to understand if protons are going to be of benefit for you, because at least in the adult population, there's probably more indications where conventional radiation delivered with photons is going to be more appropriate for you than delivery with protons. And it's important to have that discussion to know that you're being treated in the right way.
Thank you so much. And thank you also for sharing the importance of our patients and caregivers that are joining us today to engage with their healthcare team as well. Unfortunately, that is all the time that we have for questions. Thank you to all of our attendees for those wonderful questions. And thank you, Dr. Bovi, for the incredible presentation and for your thoughtful answers to our attendees' questions as well.
It's been my absolute pleasure, Amber, and thank you so much. And thank you to our audience. And again, our sponsors, Acua and Orfit. Thank you again.
Thank you. Well, again, I want to thank, just as Dr. Bovi said, I want to thank all of you for attending and joining us, and a huge thank you to our webinar sponsors for today, Orfit and Accuray. We hope that you found this webinar to be informative and beneficial. We encourage you to please take a few minutes now to scan the QR code on the screen or go to the link on the screen to complete our webinar survey. Your feedback is important to us as we plan for future programs. You'll also be receiving this survey in an email message over the next few days, along with the webinar recording and additional resources. If you're looking for more educational content like this, we hope that you can join us for our next webinar in March on all about ependymoma, what to expect during the diagnosis, treatment, and survivorship. This webinar will be taking place March 20th, presented by Dr. Sturgio Sakaroulis from Columbia University. For more information about ABTA's programs, events, and services, please visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. Thank you again for joining us and enjoy the rest of your day.
Thank you.